Welcome back to In the ED Now, a podcast that makes you an excellent emergency department physical therapist. I'm your host, Dr. Rebecca Griffith, the ED DPT, and I'm so excited to have Dr. Alex Barnes with us today. Welcome to the show. We're so happy to have you.
Awesome. Thanks for having me, Rebecca. I'm super stoked to talk with you today.
I'm excited too. And so just to give people some background about you, you are not a physical therapist in the emergency department, but I would say that you are an emergency physical therapist. So tell us a little
Mhm.
bit about your background.
Yeah, absolutely. I am not in acute care. I am not in the ED. I am a board certified residency trained sports PT. And my emergency side of what I do is I do a lot of on-field coverage and management for local high schools, club teams, and college programs. And so we serve as one of the sports medicine providers that can supplement our athletic training counterparts and EMS counterparts and any other MDs that are on field. And so I do go in and manage a lot of these acute, more traumatic emergent cases, and then having to transition an athlete potentially to the ED.
Yeah, so I often say that in the emergency department, we're first receivers, not first responders, right? So you are
Mhm.
actually a PT first responder. So speak to
Yes.
people about how you got trained to do that because I didn't roll out of PT school being able to do that.
Yes, no, graduated from PT school and had no idea about emergency management on field. I started my career at Stedman Hawkins doing a lot of post-op rehab and return to sport. And I was like, there's kind of a gap here that I'm missing. And it's really that on field to the rehab setting. And so I went and did a sports residency at Children's Hospital and Regis University. And so when in a sports residency, PTs work alongside an athletic training mentor. So you're doing on field coverage with an athletic trainer. I did it at both the high school and the college level. And we spend time in the training room preparing athletes to get onto the field, whether that's a practice or a game. And then I have like my acute medical bag where I'm doing coverage during those events. So you're making sure that somebody's not having a cardiac event, a C spine injury, some sort of fracture on site, a hip dislocation, an elbow dislocation, things like that, that would be an emergent response. And then we talk a lot about emergency action plans on how do we integrate EMS into these sort of settings. And then you have to look at every single facility that you go to. So in the state of
Mm.
Colorado, we have a lot of team sports in the Denver metro area, like your football, your gymnastics, track and field, things like that. Up in the mountains, it looks a little different. You obviously are having much more of your mountain sports, whether that's mountain biking, your cyclocross races, regular cycling races, your triathletes are training, and you also have your winter sports. So you're looking at, how is somebody responding from a concussion if it's, you're a skier, a snowboarder at the X Games. Um, I also do a lot of AAA hockey coverage, which I travel with the team, which I think is really unique in the setting that we are in. But I didn't get that exposure in residency. That was post residency. But you go through all of this training and you're supposed to spend at least 200 to 250 hours on field in the residency program. Plus, most programs are significantly more than that because you're building relationships with multidisciplinary teams and you're really on the field and in the training room doing a little bit of acute management and rehab to help with our athletic training counterparts. Um, and then through residency, took my board certification. And after, I was like, well, I kind of get the hype of like why people like being in this like exciting situation where you have to be really calm. And I love working with athletes being able to do that. So in my private practice, I then started to seek out arenas to be able to do that in. And that's how I ended up working with a AAA hockey program where we travel to Canada, Florida, Texas, Boston. They're all over this stinking place. And I'm like the head sports medicine provider of the weekend when we go on these tournaments, which is intense because that's a lot of responsibility from managing the acute injury. Because I'm in private practice, we order the images. So I might be ordering a C spine x-ray or an MRI or CT scan, depending on the need, and then communicating with whatever orthopedic physician I need to back in Denver while we're transporting or flying back, or communicating with EMS and their emergency department wherever we might be. Like I had to do that in Boston this year for a sternal fracture. So yeah, that's how I ended up in this realm, and it's fun and exciting. And now we do coverage all the time.
I think that is the coolest. And I think if you're really interested in sports, especially sports recovery and rehab, then you really want to know
Yeah.
how it starts. Like
Mm-hmm.
you want to be the one that's there that sees how it starts and sees where it goes. And I'm also wondering, as part of that coverage that you do, when you see people that are hurt immediately, but maybe not emergently, are you able to help keep them from going to the ED?
Yes. So obviously, if we have something like a cervical spine injury or something like
Please
that,
send
that is
that.
like a full team approach, we're
Yes,
obviously directing a little bit differently.
please.
But let's say we have somebody on the field that we've got an ankle sprain and somebody feels that is their athlete, they are being pulled from the second half of the game. It's like quarterfinals at state. It's a really big deal and we get them onto the sideline. There's so much adrenaline going. There's a lot of like, we have to cover the athletes so you're not getting as much exposure from the parents and the stands and the teammates and the opponents. But in that setting, you can then help a lot with like nervous system regulation and like calming the athlete
Oh,
down and really
yeah.
talking like, breath technique and helping, like, you're doing a lot of mental health support on the sideline. And then if the athlete has calmed down, I'm like, great, you've got full range of motion, full strength. You might be in some pain still, but like that's okay in sports. Like sports, you live life and you do a little bit of work in pain. Then I put them through like functional movement testing. So can they protect themselves on the field? So if they can run, jump, cut, and like do sport specific movement mechanics, I'm like, all right, I'm gonna tape you up. Like you ready to go? And then they get back on the field. If they've got bony tenderness and they're an adolescent athlete, it's over a growth plate. That's obviously more of a concern that I may pull that said athlete and be like, hey, I need to boot you. Like sending you for an x-ray is important for your growth and development. But usually if that's not the case, like they're back on the field, I might be icing the bejesus out of them after the game. And like then we're going through our rehab, making sure that they're able to go through the rest of the season. But as a sports PT, I think you have to really think about where is this athlete at in season? What are the demands of their sport and they have to be on? And is this such an emergent injury that I like have to send them to the ED? Or are there more pressing cases that we can send onto your caseload?
Yeah, because I mean, I see a lot of, I don't know, weekend warriors, rec league athletes, things like that, who just soccer's a huge
Yeah,
one, basketball, things like that, dance, where they have hurt themselves, but they're not sure if it's an emergency or not. So I think having somebody at events like that would probably be helpful.
absolutely. I mean, we're covering a 50K race this weekend, and I helped cover Leadville 100 last summer, where you've got these amazing adult athletes running a million miles because they're just an outrageous endurance athlete that I am not. But, these are the kinds of people that, going along with our ankle example, they may roll their ankle on an unstable surface and be able to be like, okay, how do I independently manage this to push through my sport? But keeping them safe, knowing you're not going to cause further damage, allowing them to stay in their activity, but knowing like, you know, you put the risk back on the athlete a little bit of, hey, you can continue to participate. You're safe. You're able to do this, but it may hurt a little bit. Is that okay with you? And like really
Yeah.
developing that like open dialogue. So yes, our weekend warriors get it just as much.
I think that's great. So, talk to me a little bit about your differential diagnosis process because in the emergency department, we're really responsible for a large piece of that. And if you're the primary team leader out there, I know you are. So, the other concept that I want you to touch on is good enough. And I think you have touched on it a little bit just now, but
Yep.
how do you know if it's good enough? Because I think a lot of PTs are afraid of like the liability that goes with differential
Yeah.
diagnosis and that liability that goes with good enough.
Oh gosh, this is a really hard topic. And I think it's really, really hard for new PTs in particular. Like my entire year and a half in residency, I struggled hard being like, are we sure I should be putting this athlete on the field? Like they still have a little bit of range of motion restriction. They still have a little bit of pain and dysfunction, but they're not at 100%. And I think that's a really hard conversation. Um, a lot of my mentors have gone on the line of like, make it back to the basics. And I know we've talked about this already on this podcast, but
Mm.
like, if somebody has functional movement, if they have full range of motion, if they have full strength, and they can participate in a way that they can react to some sort of external stimuli, they're usually pretty safe and good to go. Is there going to be like a little bit of swelling and a little bit of discomfort? Yeah, you just had an acute injury. But if we know how to manage that, even if we can get some compression on somebody and some additional external support, that's usually where I'm going for a differential diagnosis. If for some reason they have one of these injuries where, I've got a football player with a stinger and he really can't lift his arm and he's got numbness and tingling into his hand and there's risk of some sort of like neurovascular compromise, I'm clearly sending them to the ED for further evaluation, or at the very least, sitting them out and doing some sort of work on the sideline to make sure, okay, can I regain that function? Did we really just like, have like a slight tension of that brachial plexus and I'm needing to stabilize you and like calm the nerve down and then check, in about an hour, are you able to have that full range of motion? So that's really how I go about these cases. Obviously, the more like significant ones of when I have concerns for a deceleration injury that may have internal bleeding or like a head injury, that's a hard no, or C-spine or anything of that sort. But usually I'm going through those pretty basic guidelines from there.
I love that. Talk to me about head injuries, because we see a lot of folks come into the ED with head injuries. And I think, too, even once they're already in the ED, you still have to make that decision. Like, does this patient need imaging? Can I clear that cervical spine? How do I know how to counsel this patient? Like, what's your
Yeah.
best advice?
Oh man. So I think concussion is a really like hot topic right now.
Yeah.
Especially because in the state of Colorado, PTs can now clear for concussion if you have additional neurologic training. So I used to help run the concussion program at Seven Hawkins, and I taught a lot about concussion at the University of Colorado at the Anschutz Medical Campus, and it's a forever changing topic. Like a new SCAT-6 just came out. We've got a new CPG coming out. And so I think if you are a PT and you're wanting to do concussion clearance and feel comfortable with that, I would definitely recommend like staying up to date on the recent literature. The concussions consensus statements are coming out every few years. The APTA's got a wealth of information. If you're an APTA member, we've got a lot of great research that's come out and is continuing to be developed. And so I think for starters as a physician, making sure like you are top of your scope, knowing, like what is new and in the research. Like we don't cocoon kids. That's been a long found deal. I still have PTs in town call me or ATs in town saying, oh, I just recommended they sit in a dark room for 4 days.
Oh, God.
Whoa. Yeah, we don't do that anymore. They get way better with aggressive and early care. So
Yes.
from an on-field perspective, head injury last week at the hockey rink. Obviously, like when you're checking on field, you're looking for range of motion of their extremities, making sure they can wiggle their fingers, wiggle their toes. They've got a pulse. They're able to have clear sensation. Then you're checking midline tenderness of the cervical spine. That's really important to know. If somebody has midline tenderness and anything into the extremities, that's an immediate EMS call. And if that's the case, I'm stabilizing the C-spine as like the head provider on field, and you're educating coaches or other medical staff on the sideline to assist you with taking off helmet and pads. If it's like a football player. That is not the case in every single state. So making sure if you're doing out of state coverage, that you are checking in with what their EAP is and how that medical team manages these cases. Sometimes they leave the helmet and the pads on in the football setting for EMS to take off. So that they are the ones that are in control of the C-spine going into the emergency room. Typically in the state of Colorado, and how it's been taught at Children's Hospital and at many of the high schools that Children's has athletic trainers in-house at, they are the ones taking off the pads and making sure that we're able to support the occiput and the cervical spine. But if somebody has that tenderness, we are sending them into the ED. Let's say that they don't have those symptoms, but I'm pulling them because when in doubt, you're pulling them out in the state of Colorado. We're really trying to avoid secondary impact syndrome, which is very lethal, especially in the adolescent and pediatric populations. And coaches are really educated on this. So that's when our education comes in with coaching staff and parents on what are these red flags that we might be looking for, like worsening headache, worsening nausea, vomiting, etc. from there. And a lot of the school systems and teams have handouts that we provide the parents. Bless you. And then, let's say that we go through a SCAT-6 either same day or the following to really look at this individual symptoms. If it's not emergent at this point, we're really treating it in-house, and we're able to really do that. A lot of literature shows that if you can get them doing subsymptom cardiovascular training day one, their symptoms significantly decrease and they have a faster return to sport. And then if we're able to address any headache symptoms, or if they've got whiplash, and really narrow it down to see, like, does somebody have vestibular versus ocular dysfunction, and then giving them exercises that re-stimulate the system and make them feel a little crummy, but teaching nervous system regulation techniques, the athlete should be able to get on the field much faster. So it's kind of demystifying how do we treat concussion in the training room and like aggressively in the clinic, so that coaches and athletes like increase reporting. And so we're really able to
Oh.
decrease brain injury risk. Yeah.
That makes a lot of sense. I'm thinking about like a lot of our older adults who fall and hit their head and like trying to make decisions like that about those folks, and I think
Yeah.
it's a different kind of triage and screening process for sure, but a lot of the same principles apply. Like we should not be telling our older adults to stay snuggled up in a dark room for a week because then
Mm-hmm.
we've got a whole new set of consequences that go along with that. Okay, that's awesome.
Absolutely. Yeah.
So if somebody's like listening to this and they're like, okay, I still don't know. Like, what would I send to the ED? What do you
Mm-hmm.
think your like top five diagnoses are that go to the ED?
Oh, top five diagnoses: C-spine injury,
Mm,
a hip dislocation, an
please.
elbow dislocation that needs to be reduced because that kind of freaks me out a little bit. Any sort of arterial bleeding that cannot be managed. My top four. Mm, what other things do I tend to send to the EC? And then really any like spine injury in general, because I think that's like really difficult for us to stabilize on field and needs additional support. But obviously, if I'm also having somebody with some sort of like an abdominal injury as well, that would probably be like the next on my top list.
Okay.
Like I think we get a lot during football season, you see a lot of receivers get clotheslined. And then if they're having difficulty breathing, we are concerned for like pneumothorax or like liver, different, or like spleen injury. Those are definitely things that I'm like most likely sending to the ED from my perspective.
That's awesome. So other things that I could think of, open fractures,
Yep.
obviously, any kind of major fracture, I'm assuming you're sending. Otherwise, are you guys managing that like independently with orthopedic offices?
Good question. If it's an open fracture, typically we're
That's
sending
coming.
it.
Yeah.
Yeah, we're like splinting and sending.
Yes.
If it's a closed fracture, depends. When I'm in Canada with a team, I had this happen this year. The Canadian hospital system just takes significantly longer to get into the emergency department. Like I had a family call in and it was a 10-hour wait. And so in that case, we splinted him, iced him, and I actually sent him on a plane home and then was managed back in the States. So, and I think he ended up going to more an orthopedic partnership the next day versus the ED. So that's kind of how I've handled those cases if we're able to safely stabilize. If not, they got to head over.
Okay, let's talk a little bit about like environmental factors, metabolic factors, vitals. Like, how are you managing like heat related issues, cold
Oh,
related issues, electrolyte imbalances? I'm thinking like, do you know what the vitals are for all of your on-field athletes? Like, what's normal for them, what's not?
oh man, I'm like really going back to PT school and being lectured as to like why blood pressure is so important. And
Yes,
honestly,
please.
didn't realize, I mean, I knew it was important, Dan Malone, but I didn't realize how vital it is until you are like truly on field and like
Yes.
in these kind of like emergent cases. And so, when you're asking even my top five things, I haven't even thought about heat injury yet because we're, coming into spring season, but that's huge. And so with heat illness or heat stroke, like obviously heat stroke is a medical emergency. So for those listening to the podcast that are not doing as much on-field management, heat stroke is when your core temperature reaches really high levels. We're looking at above 102 to 104 degrees. And so you're starting to see a lot of symptoms that need to be managed pretty immediately. In those cases, we do use a rectal thermometer at most organizations. This is technically district by district. So there is one district in Colorado that is or school by school, I'm sorry. Are a couple schools in Colorado that do not utilize the rectal thermometer. due to wanting to protect the athlete's privacy. However, if you have not used a rectal thermometer, the athlete is completely covered. You are gloved. They are like completely shaded. It is very private and it saves a lot of lives. So if you're able to put an rectal thermometer in, and only about this big, and duct tape to the side of their leg, you can put an athlete in a cold plunge on holding their shoulders to make sure they don't faint into the water, and allow their core temperature to drop down until it's safe to transport. In the meantime, EMS is coming. There have been many studies that have shown that if we are able to cool the body prior to transport, you're able to save vital organs, you're able to
Mm.
avoid further damage of heat stroke, central nervous system disruption. And there's some really cool national speakers that come in. One is in Colorado that talk about, as an athlete, why these are such life changing situations. And I think it's more important to get the word out on, hey, this is like a life or death situation, and like, what can we do to solve that problem? So that's definitely something that's coming up. We don't see it as much in Colorado because our summers are not as hot and humid. So on field, we look at what's called the wet bulb globe temperature that looks at the humidity and the heat index and the wind and a bunch of different factors involved. Um, but in like places like Georgia and definitely down south where it's much more humid and the temperatures are significantly higher, the increased risk of heat stroke is significantly higher. Like they have a lot of studies done down in Texas and in Georgia and in the Carolinas as well.
Hmm.
Kind of, it's a scary situation, especially making sure your team is all on the same page. Like I'm a pretty petite provider, and so having a counterpart for a really big lineman is important, not only for like my biomechanics, but also like the athlete safety. And I have been in a situation where I did have a like 300-pound lineman collapse, and I was the only one in the training room. And so like the importance of like communication through even a walkie-talkie and things like that to make sure you have support staff, I'm realizing is very helpful and
Yeah, for sure.
better.
So
Yeah.
I know we don't worry too much about heat in Colorado, but we do have a lot of cold. And I would say our
Yeah.
spring and fall sports here can both have cold related and heat related issues. So
Yeah.
how do you know if you need to be watching people for cold issues?
Oh,
How do we know if there's damage? Because I know we see a lot of folks with frostbite in the ED. How do we how are we managing that?
yeah. So there are specific charts that can be found online. And if you're in a clinic-based training room or on field, can be like posted in your clinical site of whatever capacity that is, or like saved in your phone. The NATA, so the National Athletic Training Organization, has these out every year. And so there are specific temperatures and specific time frames that athletes should be performing at that a level of coldness to avoid frost nip that can turn into frostbite. Um, So to avoid that, we're really looking at the amount of exposure. And then let's say you do have somebody that's been outside for far too long. We talk a lot about covering the extremities, but not rubbing them because you want to avoid skin damage. And then slow intake of warm fluids. As we're talking about, like, do we need an ED transport? Has someone lost sensation and like lost restriction and like range of motion? And then we're probably going to send for like overall warming. But really, I was emphasized a lot in residency that the slow warming is most important. So you're not like putting the system into shock.
Yeah, I think
Yeah.
that's great. And
And yeah.
no, I think that's so smart. And I think other patient populations I can think of that are coming into the ED in similar circumstances are our unhoused patient population
Mhm.
who can be found outside and may not know that they're having those type of issues and making
Yeah.
sure that we're helping support those patients as best we can. Okay, man, there are so many things that I want to ask you. But let's talk a little bit about your experience as part of this like multidisciplinary team. Because I know in the ED, it's a very lateral hierarchy. Our opinion is well respected, and but other areas of PT, it's not so much like that. But I think for you to be successful in this environment, you must have cracked the code. So tell people how this works. I also think people
Oh,
are probably wanting to know like why you and not an athletic trainer.
great question. And I still ask myself that all the time, to be honest. So I don't know if I've cracked the code necessarily, but I think networking and like really developing strong relationships with your orthopedic counterparts like all over the state is really important. Um, I've developed a lot of relationships with physicians up in Vail and in the Front Range, but also down in Colorado or down in Denver at Children's Hospital for my more pediatric cases, at UC Health, Denver Health, and at Stedman Hawkins. I have counterparts over at Panorama and at Cornerstone. And so you're really able to kind of tailor the need and the communication structure from there, especially because two of the organizations I work with don't have an MD in house. And so there are certain insurances, for instance, that require an MD to see a patient. And if I have their contact, that we can do a virtual consultation with the patient to expedite care. And then we can make that triage communication together or triage decisions together versus passing a patient around and having them like drive all over town to manage an acute injury. Um, in the hockey setting I'm in, I got really blessed to work with the Colorado Avs previous athletic trainer. Pat Carnes is amazing. He's been with the Avs for the last 30 years and really has a lot of background in the regenerative medicine world, all the way down through high school, college, and professional athletics, working with an array of different providers. So it's really interesting when I'm at the rink, everybody's really on a level playing field. I think as you know, PTs go into different settings and you hear all the time like, oh, we are run by a physician run model. Okay. Well, you go in a training room and an athletic trainer is also going to say, well, why the heck is a PT in here? There's a lot, they talk all the time in sports, like there's a lot of ego in sports. There's a lot of ego in the health field as well.
Mm-hmm.
You know, we are constantly on these like ladder models of, oh, your DPT is not enough. Oh, your residency training is not enough. Oh, your fellowship training is not enough. Did you specialize? Do you have this experience? Okay, at what point are you a good clinician and you communicate well and you're a good people person and your soft skills matter? And do you take care of you outside of the training room so you can serve others? There's like such a balance there. And so
Yes.
you know, I've had really amazing mentors that are ATs that are brilliant. You know, a lot of ATs have their masters and higher level education. I know a lot more than a lot of PTs. And I think being able to go in and just humble yourself in a training room and be like, great, how can we work together? And I think that's what's really like leveled the playing field for us. And so there's a huge level of respect amongst our coaching staff and our athletic trainers. And now we are bringing on additional medical staff that everybody has these phenomenal backgrounds and is really supportive of each other. And so that's kind of how I feel like it's gone in that setting. In the high school setting, I work with a private high school that I do some in-house rehab and on-field coverage for. It's really the same thing of that it comes back to your relationship building. I've got a great relationship with their strength coach. I've got a great relationship with their athletic trainer. I educate the athletes a lot on, hey, please go see your AT for X, Y, and Z. You're going to see me for supportive rehab. Let me call your strength coach. Let's integrate these warm up and cool down strategies that reduce your risk of injury throughout the season. And we're all on the same team. Parents start to see that. Your athletic director sees that. You get huge community support. And so I kind of think like if that's cracking the code, I think that's cracking the code is
I
your
think so.
soft skills matter way more
And your
than your
soft
professional
skills don't
background.
just apply to your patients, right? It really, I think if you have strong soft skills, and I don't even know why we call them soft skills.
Yeah.
Like, I think we should call them like vital skills or like non-manual skills or something, because they're hard to teach. But once you're skilled at that, you're going to have therapeutic alliance with your patients, you're going to have professional alliance with your team, and you're going to provide better care. And so I think you're absolutely right that if you take those soft skills, I hate that, I have soft skills,
We need a
and
better
you
word.
use that with your teammates, you're going to be in
Mhm.
good shape. And I think that also helps communicate what we do, why we do, and how we do so that they know that we're trustworthy to do that also.
Absolutely. And it translates into the ED. Like you're saying, everybody's on a level playing field. And like, you know, when someone comes in and it's emergent case, you're, you're dropping the chaos down as much as you can to be calm and like working with your team. I don't think you have to be on a sideline or in a team sport to really have a team setting. You know, you can be in adaptive riding therapy, like equine assisted therapy, and you have an OT, a PT, an MD on staff, you might have a speech pathologist, you have parents that are part of the team, and you have a child or an adult on a horse. Like
Yep.
everybody, like that's a team. Communication is really important. We had all these back in PT school, we had all these like motivational interviewing courses. And then we started talking about communication. And I'm like, you think it should be second nature for people to know how to communicate, but it is a learned skill sometimes on how to communicate with different populations. And,
Yes.
you got to be able to do it.
Well, just to finish it up with a little bit more about communication, one of the
Yeah.
things that I talk to people about in the ED all the time is that you have to be able to calm your patient down and
Mm.
help them regulate. And because you can't ask for anything from the patient or do anything to the patient if they're not ready for that. So usually
No.
tell people you have to turn the car off before you can put the gas into it. So
Yeah.
what are your like top tips for calming people down? Because you must have to do that all the time.
Oh my gosh, I work with a lot of 15-year-old boys. Yeah, we do a lot of
Poor
calming
things.
down.
I have a
Uh,
14-year-old boy, so that's why I laugh. Like, no shade to teenage boys, but I have one, so I get that.
yeah, they are uber resilient, but like, man, I am like their worst nightmare when they are hurt. I do a lot of breath training. Like we start with like, military style of a box breathing. And I'm like, hey, we're gonna, inhale for 4, hold for 4, exhale for 4, hold for 4, or whatever count that is. I do a lot of settling techniques. I ask for consent and I put my like hands on to help put some of that increased input into their system, especially working. I think whether it's an adult, that's in a mountain biking injury or my 14-year-old hockey player, like helping someone know that they're safe allows them to calm the system down. So we talk a lot about breathing. I talk a lot about, hey, can you recall what the last play was? Like, walk me through how you're feeling right now. And it becomes this conversational piece. As they're getting back onto the field or onto an activity, if we're having a lot of issues with stress management and regulation there, we do a lot of
Yeah.
imagery work. JJ McCarthy up at Michigan is like a great image of an athlete that focuses on meditation and clearing the mind like before an event. My adult athletes do the exact same thing. And like, for instance, for this weekend's race we're covering, we have a lot of athletes that go through like a race prep routine. So I start talking to my patients on, hey, what is your morning and your evening routine? We train so hard throughout the day, whether you're in the ED and you're in these like high stress environments or you're on the field training your body really hard for an event. How are you recovering? What does that look like? For some, that's, red light therapy and, compression therapy and all these things that are really like hot in the athlete world. For others, it's journaling and deep breathing and getting a consistent sleep schedule that you're in a dark, cold room, decreasing input from the system. Other people, it's like really highlighting why certain therapeutic um, therapy strategies are helpful, whether that's somatic therapy or integrating with sports psych or a mental performance consultant. In our practice, so I have a sports psych and a mental performance consultant on staff who integrate into our rehab approaches. And I talk a lot about their mental resiliency at the beginning of rehab and like through the process and returning. But we also talk about that on like in these acute management injuries as well. I had tryouts for one of the teams that I work with last week, and had to pull a kid for a concussion, which is the like worst feeling in the world when they've traveled
Yeah.
afar and they're like gunning for the spot, and they're like angry and like want to be back on the ice. And you're like, okay,
Yeah.
let me like settle down and like let's talk about your goals. So, short term, long term, how'd you play this week? Do you think coaches saw you at your best? If not, like let's problem solve and like help them kind of calm down. Is all that happening like in the immediate injury face down on the turf? No. I'm probably working more on like breathing and like what are we doing and like talking them through so like they feel safe. But throughout that first week, like, yeah, like let's be proactive about it and give you some goals and like positive things to focus on that aren't like out of reach. Like you're not giving someone false hope. You're being like
Right.
super constructive with it.
Yes, I love that. I talk to patients a lot about like what is happening, not what if. I need
Yeah,
you to focus on what is, not what if. Because,
those controllables.
my daughter is a competitive dancer and she had a
Mm,
little bit of an injury this week and her quad is really swollen and, her joints are fine. Like everything's fine. She just got some muscle swelling and
yeah.
she's just like, what if I can never dance again? What if I can't do the recital? What if
Hmm.
and I'm like, we're gonna just dial it down. We're gonna focus on what's happening right now. What's happening right now
Right.
is we're gonna get ready for bed and everything's gonna be okay. And you're gonna sleep well
Yep.
tonight. And we'll see how this goes. And, doctor just looked at it. And
Yeah.
everything's reassuring, so doing that in the ED is really helpful as well. All
Hmm.
right. So
Hmm.
I learned a tremendous amount from this, and I really appreciate that there are people like you out there keeping patients from
Hmm.
coming into the ED when they need to. So just to wrap things up, what's your top of scope takeaway for people?
Ooh, my top of scope takeaway from people is if you are like not in some sort of national chapter or like local organization with you to collaborate on up and coming research and like information that's even being presented at conferences, jump in. I was never like a research guru early in my career. And then I got into residency and ended up being published in some research on concussion return to sport. And it opened my mind to all these different amazing factors are coming in from different area, like different sectors that you can really blend into your practice. And it's a really easy way to stay at the top of your scope. I think my second takeaway is if you want to be in a new setting and you want this sort of like on field experience or like
Mm,
emergency care, you can always jump ship and blend into another field. There's like a
yes.
million courses to do that in. Like I took an ER emergency response for the athlete course and then went into my SDS. But you can do EMT training, you can do a bunch of stuff and like flip your career a little bit. I think a lot of people get stuck in, oh, I don't want to be an orthopedic PT.
You don't have to
No,
be.
you don't have to be. You use orthopedic skills in the ED. You use
Yep.
orthopedic skills on the field. You also use acute care skills. You also like use pelvic floor rehab with athletes. There's a lot of different realms that we could like talk hours about.
Oh
Um,
my gosh, it's like being at top of scope, no matter what setting you're in.
yeah, just do it. And I think you should really love what you do. Not the
Yes.
case. Like flip the script and make it happen. There's so many people, especially after COVID, that are so miserable in the 9 to 5. Well, you don't have to be. I see patients one on one in my private practice, and then I like cap my day off and I head over to the rink. Today I've got 4 patients this morning, and then I have lunch and I'm at the rink from the afternoon for tryout. And like that's what gets me personally going in different settings. Like you can do that in anything, whether that's seeing patients, teaching Pilates, going into the emergency care, riding along in an ambulance, asking to shadow and doing a lot of volunteer work, I think also opens your exposure. And
Yes.
so, ask a lot of questions because there's a lot of really cool job opportunities out there. And like I have previous faculty that are all over the world doing like acute management coverage that I never knew about until I started having the conversation. And people are so willing to help people get into these positions that like if someone reaches out to me or you or any of our counterparts, I feel like I love being a PT because I think PT is a field where we work a lot together and want to support other professionals. So I hope that
Well,
makes it happen.
I mean, one of my biggest soapboxes is that we need to stop being PTs only in certain settings. Like,
Yeah.
we have to get out of the walls that bind us. Like, I'm going to work in a clinic.
Mhm.
I'm going to work in a hospital. I'm going to work in a rehab facility. I'm going to work in a school. Like, stop thinking about what building you're going to work in and who you want to work with and get to those people. And that's exactly what you're doing. Thank you so
Exactly.
much for being on the show today. You've been in the
Yeah.
ED now and you're officially discharged.
Perfect. Thank you so much for having me.